Bacterial meningitis is a serious infection that affects the protective layers surrounding the brain and spinal cord. These delicate layers are called the meninges, specifically the pia mater and arachnoid membrane. Between them flows cerebrospinal fluid, or CSF, which normally protects and cushions the brain. In bacterial meningitis, harmful bacteria invade this normally sterile space. Once inside, the immune system reacts aggressively. This causes intense inflammation and swelling around the brain and spinal cord. As the infection spreads, pressure inside the skull begins to rise. This increased intracranial pressure can quickly become life-threatening. At the same time, large numbers of white blood cells, especially polymorphonuclear cells, rush into the cerebrospinal fluid to fight the infection. The condition can develop very rapidly. Symptoms may appear within hours and often worsen quickly. Patients commonly experience high fever, severe headache, neck stiffness, nausea, vomiting, confusion, and sensitivity to light. In severe cases, seizures or loss of consciousness may occur. Bacterial meningitis is considered a true medical emergency. Without immediate treatment, it can lead to brain damage, hearing loss, shock, or death. Early clinical recognition is critical because every hour matters. Doctors usually begin treatment even before laboratory confirmation. This is called empiric therapy, meaning antibiotics are started immediately based on the most likely bacteria causing the infection. Rapid treatment greatly improves survival and reduces complications. The infection can affect people of all ages, but infants, older adults, and individuals with weakened immune systems are especially vulnerable. Vaccination, early diagnosis, and prompt medical care remain the most effective tools for prevention and survival. Understanding how bacterial meningitis develops helps highlight why fast action is so important. It is not just a headache or fever. It is a dangerous infection that demands urgent medical attention. Bacterial meningitis can affect people of any age, but the bacteria responsible often change throughout life. Understanding these age-related patterns helps doctors choose the right treatment quickly. In newborn babies, especially during the first month of life, the most common causes are Group B Streptococcus, Escherichia coli, and Listeria monocytogenes. These bacteria are often acquired during birth or from the surrounding environment shortly after delivery. Because a newborn's immune system is still developing, infections can spread very rapidly. As babies grow into infancy and childhood, different bacteria become more common. Streptococcus pneumoniae and Neisseria meningitidis are leading causes worldwide. Haemophilus influenza type B, also known as HIB, was once a major cause of meningitis in children. However, routine vaccination has dramatically reduced cases in many countries. Children with bacterial meningitis may develop fever, irritability, vomiting, poor feeding, or seizures. In school-aged children, symptoms often resemble those seen in adults, including severe headache and neck stiffness. In healthy adults between 18 and 50 years old, Streptococcus pneumoniae remains one of the most common causes. Neisseria meningitidis is also important because it can spread through respiratory droplets in crowded places such as schools, dormitories, or military camps. Meningococcal infections can sometimes trigger outbreaks. They may also progress extremely quickly, leading to shock or a dangerous rash caused by bloodstream infection. In older adults and people with weakened immune systems, the risk becomes even greater. Along with Streptococcus pneumoniae and Neisseria meningitidis, doctors must also consider Listeria monocytogenes and aerobic gram-negative bacilli. Aging and chronic illnesses can weaken the body's defenses, making these infections more severe and harder to treat. Certain medical situations also increase the risk of meningitis caused by unusual bacteria. After brain surgery, head trauma, or the placement of medical devices such as shunts, bacteria from the skin or hospital environment may enter the nervous system. In these post-neurosurgical cases, common pathogens include Staphylococcus aureus, C. coagulus negative Staphylococci, and Pseudomonas aeruginosa. These organisms are often more resistant to antibiotics, which makes rapid diagnosis especially important. The causes of bacterial meningitis may vary with age and medical condition, but the danger remains the same. Early recognition and immediate treatment are critical for survival and recovery. Bacterial meningitis usually begins in the upper respiratory tract. Many disease-causing bacteria first settle inside the nose and throat, an area called the nasopharynx. This stage is known as mucosal colonization. Some people carry these bacteria without becoming sick, while others develop invasive infection. The bacteria responsible are often encapsulated organisms. Their protective outer capsule helps them avoid destruction by the immune system. This allows them to survive and multiply more easily inside the body. Once the bacteria break through the lining of the respiratory tract, they enter the bloodstream. This stage is called bacteremia. The pathogens now travel throughout the body while attempting to evade immune defenses such as antibodies and white blood cells. If the bacteria survive in the blood, they may eventually reach the brain. They cross the blood-brain barrier, which normally protects the central nervous system from harmful substances and infections. Once the bacteria enter the subarachnoid space, meningitis begins to develop rapidly. Inside the cerebrospinal fluid, bacteria multiply quickly because immune protection in this area is limited. As the infection grows, the body launches an intense inflammatory response. When bacteria are damaged or destroyed, pieces of their cell walls are released. These include substances such as endotoxins and lipoteichoic acid. Instead of helping the patient, these bacterial products trigger even more inflammation. The immune system responds by releasing powerful chemical messengers called cytokines. Two important cytokines are tumor necrosis factor alpha, or TNF-alpha, and interleukin-1, also called IL-1. These inflammatory chemicals attract large numbers of white blood cells into the cerebrospinal fluid. They also make the blood-brain barrier more permeable, allowing fluid and immune cells to leak into brain tissue. As inflammation worsens, swelling begins to develop inside the brain. This swelling is known as cerebral edema, and it can occur in several forms. Vasogenic edema happens when fluid leaks from blood vessels into surrounding brain tissue. Cytotoxic edema occurs when brain cells themselves become damaged and swollen. Interstitial edema develops when cerebrospinal fluid shifts abnormally into brain tissue. All of these processes increase pressure inside the skull. Rising intracranial pressure can reduce blood flow to the brain and lead to serious complications such as seizures, coma, or permanent neurological damage. This entire process can progress very quickly. That is why bacterial meningitis requires immediate medical treatment to stop the infection and reduce inflammation before irreversible injury occurs. The symptoms of bacterial meningitis can appear suddenly and worsen very quickly. Early recognition is extremely important because delayed treatment can lead to severe complications within hours. One of the most well-known features is the classic triad of fever, neck stiffness, and altered mental status. Fever often develops first as the body responds to infection. Patients may feel weak, chilled, or unusually tired. Neck stiffness, also called nuchal rigidity, happens because inflammation irritates the meninges surrounding the brain and spinal cord. Patients often find it painful or difficult to bend the neck forward. Altered mental status can range from confusion and difficulty concentrating to drowsiness or even coma in severe cases. Family members may notice that the patient is behaving differently or responding more slowly than usual. A severe headache is another common symptom. Many patients describe it as intense, persistent, and unlike a typical headache. Bright lights may also become uncomfortable, a symptom known as photophobia. Nausea and vomiting frequently occur because increasing intracranial pressure affects the brain's normal function. As pressure rises, symptoms can rapidly become more severe. During physical examination, doctors may look for specific signs of meningeal irritation. One classic finding is the Koenig sign. In this test, extending the patient's leg causes pain or resistance because stretching the inflamed meninges becomes uncomfortable. Another important finding is the Brudzinski sign. When the neck is gently flexed forward, the patient may involuntarily bend the hips and knees. This reflex occurs because the body is trying to reduce irritation around the spinal cord and meninges. Some patients, especially those infected with Neisseria meningitidis, may develop a petechial or purpuric rash. These small red or purple skin spots are caused by bleeding under the skin and are highly characteristic of meningococcemia. This rash is an important warning sign because meningococcal infection can spread rapidly through the bloodstream and lead to septic shock. In newborns, bacterial meningitis often presents differently. Neonates may not develop the classic symptoms seen in older children or adults. Instead, they may appear lethargic, feed poorly, or become unusually irritable. Temperature instability is also common in infants. Some develop fever, while others may have abnormally low body temperature, known as hypothermia. A bulging fontanelle, the soft spot on a baby's head, may indicate increased intracranial pressure. Because symptoms in newborns can be subtle, healthcare providers must maintain a high level of suspicion. Recognizing these clinical signs early can save lives. Prompt diagnosis and immediate treatment are essential to reduce the risk of brain injury, disability, or death. Diagnosing bacterial meningitis must happen quickly because the disease can progress within hours. Doctors rely on a combination of clinical examination, laboratory tests, and imaging studies to confirm the diagnosis and begin treatment immediately. The most important diagnostic procedure is the lumbar puncture, also called a spinal tap. During this procedure, a small sample of cerebrospinal fluid, or CSF, is collected from the lower back using a sterile needle. The cerebrospinal fluid is then analyzed for signs of infection. In bacterial meningitis, the fluid often shows high white blood cell counts, elevated protein levels, and low glucose levels. The appearance of the fluid may even become cloudy because of the intense inflammatory response. Laboratory testing can also identify the exact bacteria responsible. This helps doctors adjust antibiotic therapy to target the infection more effectively. Before antibiotics are given, blood cultures should always be collected whenever possible. Blood cultures help detect bacteria circulating in the bloodstream and may confirm the diagnosis even if cerebrospinal fluid results are delayed or unclear. However, treatment should never be postponed simply to obtain perfect test results. Time is critical in bacterial meningitis. In some patients, doctors perform a computed tomography scan, or CT scan, of the head before the lumbar puncture. The purpose is to look for conditions that could make the spinal tap dangerous, especially increased intracranial pressure or mass lesions inside the brain. Certain high-risk patients are more likely to need imaging first. This includes individuals with weakened immune systems, because they are at greater risk for brain infections or abnormal lesions. Patients with a history of central nervous system disease, such as tumors or strokes, may also require a CT scan before lumbar puncture. Other warning signs include new-onset seizures, papilledema, altered consciousness, or focal neurological deficits like weakness on one side of the body. These findings may suggest dangerous pressure changes inside the skull. Papilledema refers to swelling of the optic disc seen during eye examination. It can be a clue that intracranial pressure is already elevated. Despite the importance of imaging and laboratory tests, one rule is absolutely critical. Never delay empiric antibiotic therapy while waiting for CT scans or lumbar puncture results. Doctors often begin broad-spectrum antibiotics immediately if bacterial meningitis is strongly suspected. Delaying treatment, even for a short time, can significantly increase the risk of brain damage, disability, or death. Rapid recognition, fast decision-making, and immediate treatment are the keys to improving patient outcomes in bacterial meningitis. Cerebrospinal fluid analysis is one of the most important steps in diagnosing bacterial meningitis. The fluid is collected during a lumbar puncture and provides critical information about what is happening inside the central nervous system. One of the first measurements taken is the opening pressure. In bacterial meningitis, this pressure is usually elevated, often greater than 200 millimeters of water. This happens because inflammation and swelling increase pressure inside the skull. Doctors also examine the white blood cell count in the cerebrospinal fluid. In bacterial meningitis, the count is usually very high, often between 1,000 and 5,000 cells per microliter. Most of these cells are neutrophils, which are the body's rapid response immune cells. A neutrophilic predominance greater than 80% strongly suggests a bacterial infection rather than a viral cause. Another key finding is a low glucose level in the cerebrospinal fluid. Bacteria consume glucose as they grow, and inflammatory cells also use up large amounts of energy. As a result, cerebrospinal fluid glucose often falls below 40 mg per deciliter. Doctors may also compare the cerebrospinal fluid glucose level to the blood glucose level. A cerebrospinal fluid to serum glucose ratio below 0.4 is highly suspicious for bacterial meningitis. Protein levels in the cerebrospinal fluid are usually elevated as well. Inflammation damages the blood-brain barrier, allowing proteins to leak into the cerebrospinal fluid. Levels often rise above 100 to 150 mg per deciliter. The appearance of the fluid can also provide clues. Instead of being clear and colorless, infected cerebrospinal fluid may appear cloudy or turbid because of the large number of white blood cells and bacteria present. One of the fastest laboratory tests is the Gram stain. This technique allows doctors to examine the bacteria directly under a microscope. In untreated bacterial meningitis, Gram stain results are positive in about 60 to 90% of cases. A positive Gram stain can quickly guide antibiotic selection even before full culture results become available. This is extremely valuable during the early hours of treatment. Modern diagnostic methods have also improved the speed and accuracy of detection. Multiplex PCR assays can identify bacterial genetic material within hours. These tests are highly sensitive and may still detect organisms even after antibiotics have already been started. Rapid cerebrospinal fluid analysis helps doctors confirm the diagnosis, identify the responsible organism, and begin targeted treatment as quickly as possible. In bacterial meningitis, every minute counts, and fast laboratory results can make a life-saving difference. Empiric antimicrobial therapy is the immediate use of antibiotics before the exact bacteria are identified. In bacterial meningitis, treatment must begin as quickly as possible because delays can dramatically increase the risk of death or permanent brain injury. Doctors choose antibiotics based on the patient's age, immune status, and possible source of infection. The goal is to cover the most likely bacteria while waiting for culture and laboratory results. In newborn babies, common causes include Group B Streptococcus, Escherichia coli, and Listeria monocytogenes. Because of this, neonates are usually treated with ampicillin combined with either sfotaxime or an aminoglycoside such as gentamicin. Ampicillin is especially important because it provides coverage against Listeria, a dangerous pathogen in newborns and older adults. Gentamicin may also be added to improve coverage against certain gram-negative bacteria. In infants, older children, and adults under 50 years of age, the most common organisms are Streptococcus pneumoniae and Neisseria meningitidis. Standard empiric treatment usually includes ceftriaxone or sfotaxime together with vancomycin. Third-generation cephalosporins such as ceftriaxone and sfotaxime provide broad coverage against many bacterial pathogens. Vancomycin is added because some strains of Streptococcus pneumoniae have developed resistance to standard antibiotics. For adults older than 50 years, treatment becomes broader because the risk of Listeria monocytogenes increases with age. In these patients, doctors typically use ceftriaxone or sfotaxime plus vancomycin and ampicillin. Adding ampicillin ensures that Listeria is not missed. This is especially important in older adults and people with weakened immune systems because Listeria infections can become severe very quickly. Patients who develop meningitis after brain surgery, head trauma, or hospital procedures require a different approach. These healthcare-associated infections are often caused by more resistant bacteria. Common pathogens in these cases include methicillin-resistant Staphylococcus aureus, also known as MRSA, and Pseudomonas aeruginosa. These organisms are harder to treat and may resist many standard antibiotics. For this reason, empiric therapy often includes vancomycin combined with cefepime, ceftazidime, or meropenem. These antibiotics provide strong coverage against resistant gram-negative bacteria and Pseudomonas species. Once laboratory tests identify the exact organism, doctors may narrow the antibiotic regimen to target the infection more precisely. This helps improve effectiveness while reducing unnecessary antibiotic exposure. The key principle remains simple: start treatment immediately. In bacterial meningitis, early antibiotic therapy can save lives and significantly reduce long-term complications. Adjunctive corticosteroid therapy plays an important role in the treatment of bacterial meningitis. Even after antibiotics begin killing bacteria, the body's immune response can still cause significant damage inside the brain. When bacteria break apart, they release inflammatory substances into the cerebrospinal fluid. This sudden inflammatory reaction can increase swelling, raise intracranial pressure, and worsen neurological injury. To reduce this harmful inflammation, doctors often use dexamethasone, a powerful corticosteroid medication. Its main purpose is to calm the immune response before severe inflammation develops. Dexamethasone does not replace antibiotics. Instead, It works alongside him to help protect the brain and nervous system from inflammatory damage. Research has shown that corticosteroid therapy can reduce neurological complications in certain patients. One of the most important benefits is the reduction of sensorineural hearing loss in children with bacterial meningitis. This benefit is especially significant in infections caused by Haemophilus influenza type B, also known as HIB. Before widespread vaccination, Haemophilus influenza type B meningitis was a major cause of permanent hearing impairment in children. In adults, dexamethasone has also been shown to reduce mortality in cases of pneumococcal meningitis caused by Streptococcus pneumoniae. By limiting inflammation, the medication may reduce brain swelling and improve overall outcomes. Timing is extremely important when giving corticosteroids. Dexamethasone must be administered 10 to 20 minutes before the first dose of antibiotics or at the exact same time. This timing matters because the strongest inflammatory response begins when bacteria are destroyed by antimicrobial therapy. Giving steroids early helps blunt that reaction before it becomes severe. If dexamethasone is started after antibiotics have already been administered, the benefit becomes much smaller. In some situations, delayed steroid treatment may even be ineffective or potentially harmful. For this reason, emergency treatment protocols emphasize rapid coordination between antibiotics and corticosteroid therapy. Doctors must act quickly and carefully during the first critical moments of treatment. Not every patient with bacterial meningitis will receive corticosteroids. The decision depends on age, suspected organism, and clinical guidelines. However, in the right setting, early dexamethasone therapy can significantly improve neurological outcomes. This approach highlights an important principle in meningitis treatment. Managing the infection is only part of the challenge. Controlling the body's inflammatory response is equally important for protecting the brain and preventing long-term complications. Bacterial meningitis can cause serious complications even after treatment begins. The infection and inflammation can damage both the brain and the rest of the body, especially if therapy is delayed. One major concern is the development of seizures. Swelling and irritation in the brain can disrupt normal electrical activity, leading to sudden convulsions or episodes of altered consciousness. Some patients develop focal neurological deficits. This means specific parts of the nervous system stop working properly. Weakness on one side of the body, known as hemiparesis, may occur if certain brain regions become injured. Cranial nerve palsies can also develop. Patients may experience facial weakness, difficulty swallowing, hearing problems, or double vision depending on which nerves are affected. Another dangerous complication is hydrocephalus. In this condition, cerebrospinal fluid builds up inside the brain because normal drainage pathways become blocked by inflammation. This increases intracranial pressure and may require emergency intervention. Inflammation can also damage blood vessels supplying the brain. When blood flow becomes interrupted, cerebral infarction, or stroke, may occur. This can lead to permanent neurological disability. In some cases, fluid collects between the brain and surrounding tissues, forming subdural effusions. These collections may increase pressure inside the skull and worsen symptoms. Even after surviving the acute infection, many patients face long-term complications. One of the most common is sensorineural hearing loss caused by damage to the auditory nerves or inner ear structures. Children are especially vulnerable to long-term neurological effects. Some may develop cognitive impairment, learning difficulties, or developmental delays that affect speech, behavior, and school performance. Bacterial meningitis can also trigger severe systemic complications throughout the body. Septic shock may occur when overwhelming infection causes dangerously low blood pressure and organ failure. Another life-threatening complication is disseminated intravascular coagulation, or DIC. In this condition, abnormal clotting occurs throughout the bloodstream, leading to both clot formation and severe bleeding. Hyponatremia is also common in meningitis patients. This usually happens because of a condition called syndrome of inappropriate antidiuretic hormone secretion, or SIA, which causes the body to retain excess water and dilutes sodium levels. The overall prognosis of bacterial meningitis depends on several factors. The causative organism plays a major role. Streptococcus pneumoniae is associated with some of the highest mortality rates and most severe complications. Most importantly, outcomes depend heavily on how quickly antibiotics are started. Early recognition and immediate treatment dramatically improve survival and reduce the risk of permanent neurological damage. This is why bacterial meningitis remains one of the most urgent emergencies in medicine. Fast action can truly save both lives and brain function. Preventing bacterial meningitis is one of the most effective ways to reduce serious illness and death. Vaccination has dramatically lowered the number of cases worldwide and remains the foundation of prevention. One of the most important vaccines protects against Haemophilus influenza type B, also known as HIB. Before routine immunization, Haemophilus influenza type B was a leading cause of meningitis in children. Today, widespread vaccination has greatly reduced infections in many countries. Pneumococcal vaccines also play a major role in prevention. Vaccines such as PCV13 and PPSV23 help protect against Streptococcus pneumoniae, one of the most dangerous causes of bacterial meningitis. These vaccines are especially important for young children, older adults, and people with weakened immune systems. By reducing invasive pneumococcal disease, vaccination lowers both meningitis rates and overall mortality. Meningococcal vaccines provide protection against Neisseria meningitidis. Different vaccines target different bacterial groups, including conjugate vaccines and Group B meningococcal vaccines. These vaccines are often recommended for adolescents, college students, military recruits, and individuals traveling to regions where meningococcal outbreaks are more common. Even with vaccination, close contacts of infected patients may still require additional protection. This is where chemoprophylaxis becomes important. Chemoprophylaxis means giving preventive antibiotics to people who were recently exposed to someone with meningococcal or Haemophilus influenza type B meningitis. The goal is to eliminate bacteria from the throat before infection develops. Close contacts may include household members, intimate partners, daycare contacts, or healthcare workers with direct exposure to respiratory secretions. Several medications can be used for prophylaxis. Oral rifampin is commonly prescribed and has been widely used for many years. Oral ciprofloxacin may also be used in appropriate patients because it can often be given as a single dose. Another option is intramuscular ceftriaxone, especially in situations where oral medications are not ideal. Infection control inside healthcare settings is also extremely important. Patients with suspected meningococcal meningitis are usually placed under droplet isolation precautions immediately. This helps prevent bacteria from spreading through coughing, sneezing, or respiratory droplets. Healthcare workers may wear masks and use protective measures during patient care. Droplet precautions are generally continued for the first 24 hours after effective antibiotic therapy has started. Once treatment reduces bacterial spread, the risk of transmission falls significantly. Prevention is one of the strongest tools in the fight against bacterial meningitis. Vaccination, rapid identification of exposed individuals, and proper infection control measures all work together to protect both patients and the community. We will now look at a few case reviews. Let's review an important clinical question about neonatal bacterial meningitis. This type of question commonly appears in medical and nursing exams because age-specific organisms are extremely important in diagnosis and treatment. The question asks, which organism is the most common cause of bacterial meningitis in neonates, meaning infants younger than 1 month old? The options include several well-known meningitis pathogens. Streptococcus pneumoniae is a major cause in older children and adults, but it is not the leading cause in newborns. Neisseria meningitidis is another important cause of meningitis, especially in adolescents and young adults. It is famous for causing meningococcal outbreaks, but it is less common in neonates. Haemophilus influenza type B, or HIB, was once a major pediatric pathogen before widespread vaccination programs reduced cases dramatically. However, it is also not the most common cause in newborn infants. The correct answer is Group B Streptococcus, specifically Streptococcus agalactiae. Group B Streptococcus is one of the leading causes of neonatal meningitis and sepsis. These bacteria are commonly found in the mother's gastrointestinal and genital tract. During labor and delivery, the bacteria can be transmitted from mother to baby. Because newborn immune systems are still immature, the infection can spread rapidly into the bloodstream and central nervous system. This is why pregnant women are routinely screened for Group B Streptococcus late in pregnancy. If the mother tests positive, antibiotics are often given during labor to reduce the risk of transmission to the baby. Neonates infected with Group B Streptococcus may develop symptoms such as poor feeding, lethargy, irritability, temperature instability, or breathing difficulties. In severe cases, meningitis and septic shock may occur. Remembering age-related organisms is extremely important in medicine because empiric antibiotic therapy depends heavily on the patient's age group. For neonates, doctors must always think about Group B Streptococcus, Escherichia coli, and Listeria monocytogenes when selecting initial treatment. A simple memory tip is this: newborns are especially vulnerable to bacteria acquired during birth. That is why Group B Streptococcus is such an important neonatal pathogen. So, for this question, the best answer is clearly choice C, Group B Streptococcus, also known as Streptococcus agalactiae. Let's work through another important bacterial meningitis case review. Questions like this test your ability to choose the correct empiric antibiotic therapy based on the patient's age and risk factors. The patient is 65 years old and arrives with fever, headache, and altered mental status. These are classic warning signs of possible bacterial meningitis, and treatment must begin immediately, even before lumbar puncture results are available. The question asks which empiric antibiotic regimen is most appropriate. Option A includes ceftriaxone and vancomycin. This combination is commonly used in younger adults because it covers major organisms such as Streptococcus pneumoniae and Neisseria meningitidis. However, this patient is older than 50 years old, which changes the treatment approach. In older adults, doctors must also consider Listeria monocytogenes. This organism becomes more common with aging and weakened immunity, and it is not adequately covered by standard cephalosporins like ceftriaxone. That is why option B is the correct answer. Ceftriaxone, vancomycin, and ampicillin together provide broader coverage for the organisms most likely to affect older adults. Ceftriaxone offers strong coverage against many common bacterial pathogens. Vancomycin is added because some strains of Streptococcus pneumoniae may be resistant to standard antibiotics. Ampicillin is the key addition here because it specifically covers Listeria monocytogenes, which is a critical concern in patients older than 50 years. Option C, ampicillin and gentamicin, is more commonly associated with neonatal infections rather than standard empiric therapy for older adults with suspected meningitis. Option D, vancomycin and cefepime, is typically used in healthcare-associated meningitis or post-neurosurgical infections where resistant organisms like Pseudomonas aeruginosa and MRSA are concerns. This patient's presentation fits classic community-acquired bacterial meningitis in an older adult, making option B the best choice. A useful exam tip is this. Whenever a meningitis patient is older than 50 years old, always think about Listeria coverage. That usually means adding ampicillin to the antibiotic regimen. Early empiric therapy is extremely important because bacterial meningitis can progress rapidly. Doctors should never wait for lumbar puncture results before starting life-saving antibiotics if the disease is strongly suspected. So, the correct answer is clearly choice B, ceftriaxone, vancomycin, and ampicillin. Let's review another high-yield meningitis question focused on cerebrospinal fluid findings. Understanding CSF patterns is extremely important because they help doctors quickly distinguish bacterial meningitis from viral or other causes. The question asks which CSF profile is most characteristic of acute bacterial meningitis. Option A describes normal opening pressure, lymphocytic predominance, normal glucose, and normal protein. This pattern is more consistent with normal CSF or possibly mild viral infections, not acute bacterial meningitis. Option C includes neutrophilic predominance, but the glucose is elevated and protein is normal. That combination does not fit the classic bacterial meningitis picture. Option D mentions elevated opening pressure and decreased glucose, which can occur in bacterial infection. However, it describes lymphocytic predominance instead of neutrophilic predominance. Lymphocytes are more commonly associated with viral meningitis or certain chronic infections such as tuberculosis. The correct answer is option B, elevated opening pressure, neutrophilic predominance, decreased glucose, and elevated protein. Let's break down why this pattern is so important. In bacterial meningitis, inflammation increases pressure inside the skull. This leads to an elevated opening pressure during lumbar puncture. The white blood cell count in the CSF also rises dramatically. Most of these cells are neutrophils, which are the body's primary defense cells against bacterial infections. This neutrophilic predominance is one of the strongest clues pointing toward a bacterial cause. Glucose levels become decreased because bacteria consume glucose for energy. Inflammatory cells also use large amounts of glucose during the immune response. At the same time, inflammation damages the blood-brain barrier. Proteins leak into the cerebrospinal fluid, causing elevated protein levels. So, the classic CSF findings in acute bacterial meningitis are easy to remember: high pressure, high neutrophils, low glucose, and high protein. A useful memory trick is this: bacteria create a hot and crowded CSF environment. Pressure rises, neutrophils flood in, glucose gets used up, and protein leaks into the fluid. These laboratory findings help doctors rapidly confirm the diagnosis and begin life-saving treatment as quickly as possible. Recognizing the classic CSF pattern is essential because bacterial meningitis is a true medical emergency. Early diagnosis and rapid antibiotic therapy can dramatically improve survival and reduce long-term neurological damage. So, for this question, the best answer is clearly choice B: elevated opening pressure, neutrophilic predominance, decreased glucose, and elevated protein. Let's review another important clinical decision-making question in bacterial meningitis. This one focuses on when a head CT scan should be performed before a lumbar puncture. Remember, lumbar puncture is essential for diagnosing meningitis, but in some patients, doing it too early can be dangerous. The question asks which clinical scenario requires a head CT scan before performing the lumbar puncture. Option A describes a 20-year-old college student with fever, neck stiffness, and a normal neurologic exam. This patient has classic meningitis symptoms, but no warning signs suggesting dangerous intracranial pressure or brain shift. In this situation, doctors usually proceed directly to lumbar puncture without delaying diagnosis. Option B describes a healthy adult with severe headache and photophobia. While these symptoms are concerning for meningitis, there are still no focal neurological deficits or major red flags requiring imaging first. Option D involves a 6-month-old infant with irritability and poor feeding. Infants can present atypically, but this scenario alone does not automatically require CT imaging before lumbar puncture. The correct answer is option C: a 60-year-old patient with altered mental status and newly discovered left-sided hemiparesis. This patient has focal neurological deficits, specifically weakness on one side of the body, along with altered mental status. These findings raise concern for increased intracranial pressure, mass effect, stroke, or brain swelling. Performing a lumbar puncture in this setting without prior imaging could potentially trigger brain herniation, a life-threatening emergency where brain tissue shifts because of pressure changes. That is why a head CT scan is recommended first in high-risk patients. Important indications for CT before lumbar puncture include altered consciousness, focal neurological deficits, new-onset seizures, papilledema, immunocompromised state, or a history of central nervous system disease. A useful memory tip is this: if the brain may already be under dangerous pressure, image first before performing the spinal tap. However, there is another critical rule in meningitis management. Even if CT imaging is needed, empiric antibiotics should never be delayed while waiting for scans or lumbar puncture results. Doctors often start antibiotics immediately after blood cultures are obtained because bacterial meningitis can worsen rapidly within hours. So, in this question, the best answer is clearly choice C because altered mental status combined with focal neurological deficits makes CT imaging necessary before lumbar puncture. Let's review another high-yield treatment question in bacterial meningitis. This one focuses on the correct timing of adjunctive dexamethasone therapy. The question asks, when should dexamethasone be administered during the treatment of acute bacterial meningitis? Option A says 24 hours after starting antibiotics. That timing is too late because the strongest inflammatory response happens very early, right when bacteria begin to break apart. Option B suggests giving dexamethasone only if the patient develops seizures. That is incorrect because the medication is not mainly used to treat seizures. Its primary role is to reduce inflammation inside the central nervous system. Option D recommends giving dexamethasone after completing the antibiotic course. By then, the major inflammatory damage has already occurred, so the treatment would not provide the intended benefit. The correct answer is option C. Dexamethasone should be given 10 to 20 minutes before or at the same time as the first dose of antibiotics. This timing is extremely important. When antibiotics begin killing bacteria, bacterial cell walls break apart and release inflammatory substances into the cerebrospinal fluid. These substances trigger a strong immune reaction inside the brain and meninges. Inflammation increases, swelling worsens, and intracranial pressure can rise rapidly. Dexamethasone helps blunt this inflammatory response before it becomes severe. That is why the medication must be given early, ideally before the bacteria start breaking down. Research has shown that early corticosteroid therapy can reduce neurological complications, especially hearing loss in children with Haemophilus influenza type B meningitis. In adults with pneumococcal meningitis, dexamethasone has also been associated with reduced mortality and improved outcomes. A useful memory tip is this: steroids must arrive before the inflammatory storm begins. If dexamethasone is delayed until after antibiotics are already circulating, the protective benefit becomes much smaller and may even disappear completely. This is why emergency treatment protocols emphasize rapid coordination between antibiotics and corticosteroids during the first critical minutes of care. It is also important to remember that dexamethasone is considered adjunctive therapy. It supports treatment, but it never replaces antibiotics. Rapid antimicrobial therapy remains the most important life-saving intervention. So, for this question, the best answer is clearly choice C. Administer dexamethasone 10 to 20 minutes before or concurrently with the first dose of antibiotics. Let's review another classic bacterial meningitis case question. This scenario describes a 19-year-old college student with fever, neck stiffness, and a rapidly progressing petechial and purpuric rash. These findings should immediately raise concern for meningococcal meningitis, a medical emergency that can become life-threatening within hours. The question asks which organism is the most likely cause. Option A is Streptococcus pneumoniae. This bacterium is a major cause of bacterial meningitis in adults, but it is not typically associated with a rapidly spreading petechial or purpuric rash. Option B is Listeria monocytogenes. Listeria usually affects newborns, older adults, pregnant women, and immunocompromised patients rather than healthy college students. Option D is Escherichia coli. E. coli is more commonly linked to neonatal meningitis and certain hospital-associated infections. The correct answer is option C. Neisseria meningitidis. Neisseria meningitidis is strongly associated with meningococcemia, a bloodstream infection that can rapidly spread throughout the body. One of its most characteristic features is the development of petechial and purpuric skin lesions. Petechiae are tiny red or purple spots caused by bleeding under the skin, while purpura refers to larger areas of bleeding. This rash occurs because the bacteria trigger widespread inflammation and damage to blood vessels. In severe cases, patients may develop disseminated intravascular coagulation, septic shock, and multi-organ failure. College students are considered a higher risk group because Neisseria meningitidis spreads through respiratory droplets and close contact. Crowded living conditions such as dormitories can increase transmission. Symptoms often begin suddenly with fever, headache, neck stiffness, nausea, vomiting, and sensitivity to light. The rash is an especially important warning sign because it suggests bloodstream involvement and severe invasive disease. A useful exam clue is this: fever, meningitis symptoms, and a petechial rash together strongly point toward Neisseria meningitidis. This infection requires immediate treatment with empiric intravenous antibiotics and strict droplet precautions to prevent spread to others. Close contacts may also need prophylactic antibiotics such as rifampin, ciprofloxacin, or ceftriaxone to reduce the risk of secondary infection. Rapid recognition is critical because meningococcal disease can progress extremely quickly, even in young healthy individuals. So, for this question, the best answer is clearly choice C, Neisseria meningitidis. Let's review another important prevention question related to meningococcal meningitis. This topic is especially high yield because Neisseria meningitidis can spread rapidly among close contacts. The question asks, what is the recommended chemoprophylaxis for close household contacts of a patient diagnosed with meningococcal meningitis? Option A suggests oral amoxicillin for 7 days. Although amoxicillin is useful for certain bacterial infections, it is not the standard prophylactic treatment for Neisseria meningitidis exposure. Option C mentions a single dose of intravenous vancomycin. Vancomycin is used to treat serious infections, but it is not recommended for meningococcal prophylaxis in exposed contacts. Option D recommends oral doxycycline for 14 days. Doxycycline is used in several infectious diseases, but it is not the preferred standard prophylaxis for meningococcal exposure. The correct answer is option B, oral rifampin for 2 days. Rifampin is one of the most commonly used medications for meningococcal chemoprophylaxis. Its purpose is to eliminate Neisseria meningitidis from the nasopharynx before infection develops. This is important because people can carry the bacteria in their throat without showing symptoms. Even healthy individuals may spread the organism to others through respiratory droplets. Close household contacts are considered high risk because they are exposed to coughing, sneezing, saliva, and prolonged close interaction with the infected person. Other high-risk contacts can include roommates, intimate partners, daycare contacts, or healthcare workers directly exposed to oral secretions. Chemoprophylaxis should be started as soon as possible after exposure because meningococcal disease can progress very rapidly. Rifampin is usually given orally for 2 days and is highly effective at reducing bacterial carriage. Alternative prophylactic options may include ciprofloxacin or intramuscular ceftriaxone, depending on patient age, pregnancy status, allergies, and local guidelines. A useful memory tip is this: meningococcal exposure requires rapid protection for close contacts, even if they feel completely healthy. This approach helps prevent secondary cases and limits outbreaks in households, schools, dormitories, and other crowded environments. It is also important to remember that patients with suspected meningococcal meningitis are placed under droplet precautions during the first 24 hours of effective antibiotic treatment. Prevention plays a major role in controlling meningococcal disease. Early recognition, prompt treatment, vaccination, and appropriate prophylaxis all help protect both individuals and the community. So, for this question, the best answer is clearly choice B, oral rifampin for 2 days. Let's finish with one more high-yield case review. This question focuses on long-term complications in children, and it's a favorite topic on exams and in clinical practice. The question asks, what is the most common long-term neurologic complication of bacterial meningitis in children? Is it blindness, spastic paralysis, or chronic bleeding around the brain? The correct answer is actually sensorineural hearing loss. Hearing loss is one of the most common lasting complications after bacterial meningitis. This happens because inflammation can damage the inner ear and auditory nerve pathways. Even after the infection is treated successfully, some children may develop partial or permanent hearing problems. That's why early diagnosis and rapid treatment are so important. Children recovering from meningitis often need hearing evaluations during follow-up care. Early detection helps improve speech, language, and developmental outcomes. Now let's quickly review the other choices. Blindness can occur, but it is much less common. It's usually linked to severe neurologic injury or increased intracranial pressure. Spastic quadriparesis means weakness and stiffness in all four limbs. This is a rare but severe complication caused by major brain injury. Chronic subdural hematoma is also uncommon in bacterial meningitis. It involves persistent blood collection around the brain. So remember this key exam point. The most common long-term neurologic sequela in children is sensorineural hearing loss. This is exactly why adjunctive dexamethasone may be used early in treatment. It can help reduce inflammation and lower the risk of hearing damage, especially in children with Haemophilus influenza type B infection. The big takeaway here is simple. Bacterial meningitis is not only life-threatening in the acute phase. It can also leave lasting neurologic complications even after recovery. That's why prevention through vaccination is incredibly important. And it's why rapid antibiotic treatment can truly change outcomes. Here's another important clinical scenario. This question focuses on healthcare-associated meningitis, especially infections that occur after brain surgery or shunt placement. The case describes a patient who develops meningitis after a neurosurgical procedure. A ventricular shunt is a major clue here. In these situations, we worry about hospital-acquired organisms. These bacteria are often more resistant and more dangerous. The correct answer is vancomycin plus cefepime. This combination gives broad empiric coverage while doctors wait for culture results. And in meningitis, timing is critical. Vancomycin is included to cover resistant gram-positive organisms. That includes MRSA and CO agulus negative staphylococci. These bacteria commonly infect ventricular shunts and surgical hardware. They are frequent causes of post-neurosurgical meningitis. Cefepime is added for strong gram-negative coverage, especially against Pseudomonas aeruginosa. Pseudomonas is an aggressive hospital-associated pathogen, and it's a major concern after neurosurgery or head trauma. Now let's look at why the other answers are less appropriate. Penicillin G and ampicillin do not provide enough resistant gram-negative coverage. They would miss many healthcare-associated organisms. Ceftriaxone and ampicillin work better for community-acquired meningitis, especially in older adults where Listeria coverage matters. Ciprofloxacin and metronidazole are not standard empiric therapy for bacterial meningitis, and they do not provide optimal CNS coverage in this setting. This question highlights a key clinical principle. The source of infection helps guide antibiotic choice. Community-acquired meningitis and hospital-acquired meningitis are treated differently, because the likely organisms are completely different. That's why a careful patient history is so important. Recent surgery, trauma, or implanted devices can completely change management. Another important point is that ventricular shunts themselves can become infected. Sometimes the hardware must be removed or replaced to fully control the infection. So remember this high-yield takeaway. Post-neurosurgical meningitis requires coverage for MRSA and Pseudomonas. And the classic empiric regimen is vancomycin plus cefepime. Let's break down what actually causes the dangerous brain swelling in bacterial meningitis. This question focuses on the inflammatory cascade. And this process is what makes meningitis so life-threatening. The correct answer is the release of bacterial cell wall components that trigger cytokines like TNF-alpha and IL-1. Here's how it works. When bacteria enter the subarachnoid space, the immune system immediately reacts. But the major damage is not caused by the bacteria alone. A lot of the injury comes from the body's own inflammatory response, especially after bacteria begin to break apart. As bacterial cell walls are destroyed, they release toxic components. These include endotoxins and lipoteichoic acid. These substances activate immune cells inside the central nervous system. That triggers the release of powerful inflammatory cytokines. Two major cytokines are TNF-alpha and interleukin-1, also called IL-1. These chemicals increase blood-brain barrier permeability. Once the blood-brain barrier becomes leaky, fluid starts moving into brain tissue. And that leads to cerebral edema, or brain swelling. This swelling increases intracranial pressure, and that can reduce blood flow to the brain. As pressure rises, patients may develop seizures, confusion, coma, or even brain herniation. That's why bacterial meningitis is a true medical emergency. Now let's quickly review the incorrect answers. Direct viral invasion of brain tissue is more consistent with viral encephalitis, not bacterial meningitis. So choice A is incorrect. Autoimmune demyelination occurs in diseases like multiple sclerosis. That is not the primary mechanism here. Eosinophil accumulation is usually linked to parasitic or allergic conditions, not classic bacterial meningitis. This question teaches a very important concept. Much of the neurologic damage comes from inflammation, not just infection alone. And this is exactly why dexamethasone can be helpful. It reduces the inflammatory response before antibiotics cause rapid bacterial lysis. So remember the key takeaway. Bacterial cell wall breakdown triggers cytokine release. Cytokines drive inflammation, and inflammation leads to cerebral edema and neurologic injury.